Hello. Ma'am, good morning. Hmm. Hello. Good morning, madam. Hello.
Are we audible?
Hello.
Manorji, are we audible? Just to check. You are on mute. Thank you. Thank you.
Okay, sir.
Check, check. Hey, hey.
Good morning, esteemed guests and speakers and our moderators. To Palmogard, we are here to delve with that the field where it's constantly evolving and impacting lives in performed ways. The Palmogard is a testament to our shared commitment and advancing medical knowledge and patient outcomes. Before we begin, we would like to talk about our corporate, that is our Hetero Healthcare, with a brief video of our corporate.
Committed to improving lives. For over 30 years, our journey has been driven by one purpose: to enhance the quality of life through continuous innovation and advanced healthcare solutions. Presence in 126 plus countries with 36 state-of-the-art manufacturing facilities. Backed by a century's worth of experience, our team relentlessly pursues excellence. We aim to improve the people's quality of life with a wide product range encompassing multiple specialties and continuous research and development process with 1,000 plus top-notch scientists. We are more devoted to finding tomorrow's cure and the treatments for some of the most critical diseases. Over 2 decades of experience in developing API, among the largest manufacturers of APIs and FDFCs in the world, is a testament to a commitment to high quality ingredients, pushing the boundaries of healthcare solutions. 21,000 employees working globally. In just few years, we introduced 4 groundbreaking, 300 plus products, 314 formulation, distinction of bringing 4 biosimilar products. 5 years of initiation, Cardipoitin Alpha, Rituximab, Balsizumab, Adalimumab, and 360-degree solution provider, revolutionizing treatment for billions. Our product range spans multiple specialties, from antiviral medicines to pioneering innovations like fluid. During COVID-19 pandemic, Govifort Remdesivir is our contribution to serve country and humanity, instrumental in the fight against COVID-19. Our achievements are recognized globally. One Express Pharma Excellence Award for COVID-19 drug launch, rewarding our contribution to provide Govifort Remdesivir access to more than 1 lakh patients. Largest manufacturer of HIV drugs,
largest manufacturer of antiretroviral drugs, manufacturer of wide range of anti-cancer drugs. Our commitment to innovation goes beyond healthcare. In June 2023, our sister company, Azista BST Aerospace, proudly launched its first microsatellite, marking a new milestone. As doctors care for their patients, We Care for You initiative fosters a unique bond of trust, offering support not just through products. We Care for You is not just an initiative, but an emotion committed to you and your paramedical staff. Hetero Healthcare is committed to a healthier world for everyone.
Thank you. Now we would like to welcome our esteemed guest and speakers. I'll request Silas sir to come forward and welcome our esteemed guest, Dr. Prashant Jhajar sir. Please do come on the platform, sir. Oh. Now I'd like to request Khandeparkar sir, Dr. Khandeparkar sir, to welcome Dr. Prabhu Desai sir. Now we would like to begin our program, and I'd like to request Dr. Khandeparkar sir to take it over, please.
Thank you. Once again, a warm welcome to all of you to this scientific summit on COPD. Throughout the summit, the HCPs will have opportunity to engage with the experts through presentation, panel discussions, and together we can pave the way for a future where respiratory diseases are better understood and treated, and ultimately improving the quality of life of countless individuals. Dear all, we look forward to your active participation and to the stimulating discussion that will undoubtedly arise from the gathering. Once again, I thank you for this joining us on the scientific summit. Today, we have got a panel consisting of eminent chest physicians, Dr. Prahlad Prabhudesai, Dr. Prashant Chajil. Welcome, sir, to this. Dr. Prahlad Prabhudesai, moderator and speaker, MD, DNB, FCCP, consultant chest physician at Lilavati Hospital Research Center, postgraduate teacher for DNB chest medicine, course director for bronchoscopy, basic and advanced at IMM AST, Director of Pratibha Prabhakar Pulmonary Rehabilitation Center, which provides respiratory patients health beyond medicine. Sir was felicitated in December 20 by Governor of Maharashtra as COVID Yuddha. Felicitated for inspiring chest physician. Has 62 publications in national journals and international journals. Member of Indian Chest Society, European Respiratory Society, Indian Association of Sleep and Respiratory Disorders, and Fellow of American College of Chest Society. Welcome, Dr. Prabhu. A speaker for today, PD Dr. Prashant Chajil, MBBS, DETRD, MD, DNB, FCCP. Sir is interventional pulmonologist, Director Lung Care and Sleep Center, Mumbai. Head of Respiratory Medicine, Fortis Hiranandani. Senior Consultant, Lilavati Hospital and Nanavati Hospital, Mumbai. Associated with several committees like Indian Association for Bronchology, Interventional Pulmonology Group, European Respiratory Society, Indian Chest Society, American Thoracic Society, American College of Chest Physicians, etc. Has 153 journal publications and 5 book chapters. Won several awards for best paper and best presentation. Sir is associated with various journals in different capacities, just to name a few: Respiration, Journal of Bronchology and Interventional Pulmonology, Lung India, Indian Journal of Chest Disease and Allied Sciences, American Journal of Respiratory and Critical Care, Journal of Association of Physicians of India, Thorax, etc. Dr. Chajil is member of European Respiratory Society, American College of Chest Physicians, American Thoracic Society, Indian Association of Bronchology, Indian Chest Society, Association of Physicians of India, Indian Society of Critical Care Medicine. welcome Dr. Prashant Chaje. And I now welcome Dr. Prashant Chaje to take the proceedings further. Sir, please.
So thank you very much for this very generous and kind introduction. And thank you for this invitation to speak here. And it's always an honor and privilege to share the dais with Dr. Prabhu Desai. So I think the topic for today is about COPD. And I mean, the more we read about COPD, the more we understand the problems associated with COPD and what more we can do for patients with COPD. The topic that has been given today is about epidemiology and early diagnosis of COPD, and the other topics would be taken by Dr. Prabhu Desai. So whenever we talk about epidemiology, it's also often considered a quite boring thing, but I think it's something really very interesting. I've tried to simplify things as far as the epidemiology is concerned, so that we understand what is the level of problem that our country faces, what is the global problem, and what is the gravity of the problem, and what we need to do, what are the gaps that need to be fulfilled in order to manage COPD better and tackle this problem better. So when we talk about COPD, this is the Goal 21 definition. It's a common preventable, the word is preventable and treatable disease characterized by persistent respiratory symptoms, airflow limitations that is due to airway and or alveolar abnormalities caused by significant exposure to noxious particles or gases. So when we say about airway, we are talking about bronchitis. When we talk about the alveolar abnormalities, we're talking about emphysema. So now this is 2025, and now this is a very important table, I would say. It talks about the etiotypes for COPD. This is the first time the gold goes in this direction. And if you see here, there are different types of you can say one is COPD-G is genetically determined COPD. That could be alpha-1 antitrypsin commonly. One is COPD due to development abnormalities. This is early life events such as premature death and low birth weight can cause COPD. Then you have environmental COPD, that is COPD associated with cigarette smoking, that is COPD-C. And now this is biomass and pollution exposure COPD. And I think India takes a lot of credit in terms of identifying this problem and also the gravity of this problem, and also contributing to the research as far as the biomass and pollution exposure COPD is related. This could be exposure to household pollution, ambient air pollution, wild and occupational hazards. But household pollution and ambient pollution is a problem in India and many other countries. But household pollution, our chula fume exposure, biomass gas exposure is an important cause of COPD. Then another important etiotype, that is COPD due to infections. We often knew that our TB patients eventually, when they heal, a lot of them have obstructive airway disease. There was no such name or categorization given to them. Now they come under the category of COPD-I, that is infection or tuberculosis associated COPD, and some people also call it TOAD, that is tuberculosis associated obstructive airway disease. And then you have a COPD which is related to asthma, where uncontrolled asthma, severe asthma can eventually lead to COPD. So these are the risk factors that we are talking about as far as COPD is concerned. And now this is an important concept that we need to understand, where if we have to really also understand the epidemiology, the global epidemiology, and where India also stands within the global scenario as far as the burden of COPD is concerned, and as far as also our problem is there. So what is DALI? That is a disability adjusted life year. Okay, is a measure of overall disease burden expressed as a cumulative numbers of years lost due to ill health, disability, or early death. Okay, so it is equal to years lived with disability plus years of life lost. So just to understand, it is a disability adjusted life year. Okay, and we will come across this as we go further. So respiratory diseases are responsible for approximately 32% of DALIs in India, out of which 75% is attributed to COPD. Look at the burden of respiratory and look at the burden of COPD. So you can almost extrapolate. We're looking at COPD contributing to 20 to 25% of Delhi. What's the global burden of COPD? It's estimated at 10.3%. Annual 3 million deaths occur due to COPD. The prevalence of COPD is expected to rise with increasing rates in smoking in low and middle income countries and the aging populations in high income countries. So these are the factors here. So 3 striking findings on COPD prevalence: higher prevalence in smokers and ex-smokers compared to non-smokers, increased prevalence in individuals aged more than 40 years, and a higher prevalence in men compared to women. And we'll come across, if you look at the etiotypes, we have a lot of non-smoking COPD also. So if you look at the COPD timeline, it's an alarming rise. 1990s, you see the Delhi's were 59.2 million. Then in 2005, COPD ranked as 8th leading cause of Delhi loss worldwide. COPD rose to the 5th leading cause of global Delhi loss from 8 to 5. And in 2019, global COPD Delhi increased by 25% since 1990 from 59.2 million to 74.4 million. And largest Delhi increases are observed in Southeast Asia, India, and Africa. So that's the problem of COPD. And you see that in India also the problem is really almost on a steep rise. Some of the slides may be repetition just for the sake of simplicity. If you look at the global prevalence, it's 25.251 million here, and India has 55 million. That is a 21, almost 22% of global burden is in prevalence is in India. And if you look at the deaths, 28% or 29% of the deaths, COPD deaths, are happening in India. And if you look at the DALYs, that disability life adjusted life years, you're looking at 35% is contributed by India. So COPD, the prevalence is high, the death is high, and also the disability is high compared to what the number of cases we share from the world prevalence point of view. So COPD is a #1 cause of morbidity and mortality. If you look at the COPD again from the graphical way, this is 37.8 million we are looking at. We already went through this. And now the burden of COPD in India, again to summarize, we are looking at, the second, the cause of total number of deaths is second in 2019, and cause of deaths and disability in 2019 is ranking 3rd in the country. So that's the burden of COPD. Now, if you look at this graph, map of India in COPD 1990, and this is the prevalence here, and you clearly see it. These are the colors which represent a higher prevalence, and look at all these areas which have changed their color, and a remarkable increase in COPD prevalence, burden of COPD in North as well as West and South India. So when we look at the COPD facts from India, 1 in 3 COPD patients is a never smoker. 85% are feared for worsening of symptoms due to weather change. Every 1 in 2 COPD patient gets hospitalized at least once in a year, and 46% of COPD patients are exposed to biomass smoke. So that biomass smoke, the biomass exposure is a non-smoking COPD, is an important cause of COPD in our country. So where are we headed? From an epidemiological trend point of view, the Gold report quotes that COPD cases amongst individuals aged 25 years and older, we're now start to talk about 25 years and older, are projected to increase by 23% from 2020 to 2050. The number of global cases approaching 600 million by 2050. That is 60 crore. That's 60 crores. Okay, that is what we are looking at. By 2060, it is estimated 5.4 million deaths annually caused by COPD and its related conditions. And the important point is, it is still underdiagnosed. So it's also a silent catalyst for lung cancer. We know that adenocarcinoma is increasing, worldwide and increasing in our country. In India, we reported it actually in 1998 that the trend is moving towards adenocarcinoma, but squamous cell carcinoma still associated with smoking. In COPD, this is just a review of what we discussed. The situation seems to be quite grim as far as India is concerned. It's a leading cause of death, second highest contributor to mortality and morbidity. As far as non-communicable diseases go, it accounts for a high number of percentage of the global cases. And if you look at the age trends, we always spoke about COPD, initially 50 to 60 years and above, then 40 years and above, and now dismally, the goal says we now start to think about 25 years and above. What is the regional variability within India? If you see here, northern India is 10.4%, southern India is 3.7%, and eastern India is 6.8%. So this is the breakup that we are seeing. Of course, India lacks proper data collection as far as epidemiological data is concerned, but whatever is coming through is compiled here. So it's a growing economic burden as well. If you look at an acute exacerbation causes at least 45,000 rupees. This is averaged out. Of course, this can vary from a corporate hospital to a small grade hospital, but eventually there is some basic minimum cost, and you can average it out to 45,000 rupees. There's a disproportionate impact on low-income population. Now, look at low-income population. We know what is the income of our our low-income patients, and one is if they may avail government services. Sometimes they may not be able to avail government services. May not have access to insurance. Then it's a lot of out-of-pocket pay. Chalo, these are all the financial bits, but also for them, loss of work is extremely important. So loss of work is loss of salary and loss of income. So the lower and middle income class bears a very big burden as far as COPD is concerned. So now that I've given you an overview about of my first part of the talk was what is the epidemiology of COPD global, and what is the status in India. And the second part of the talk now is about early diagnosis of COPD. What can we do? So, the first slide said that COPD is a preventable and a treatable disease. So if it's a preventable and treatable disease, how can we take some steps forward? As one is, if of course prevention is at a global level, but at a more broader level. But if an individual is affected, we need to start seeing how we can diagnose them better. So identify patients for whom a diagnosis of COPD should be considered. That's very important. We need to start thinking. Identify the signs and symptoms suggestive of COPD, understand the diagnostic criteria for COPD, and differentiate between COPD and asthma. So this is an abstract that was published, that was presented about 10 years ago, and it showed that it was a survey of 47 pulmonologists across India. Data was obtained from 247 newly diagnosed patients, and the key finding was the first time a pulmonologist sees a COPD patient, the patient is already in the severe stage. What does it mean? It means physicians and general practitioners, being the first point of contact for all health-related issues, including COPD, need to start identifying COPD early. And how can we do that? There are some questions that can suggest COPD. One is asking, do you feel breathless every day? Do you smoke? Do you get breathless while doing your routine activities? Do you have a persistent cough? Do you expel sputum while coughing? Do your symptoms worsen with climate changes? And are your symptoms worse at work than home? That's in case of an occupational COPD, where the individual is exposed to gases or chemicals or metal dust or etc. at work. Of course, these observations can suggest COPD are at a much advanced stage when there's a flare-up or something. But I think these questions are extremely important, which can be incorporated whenever an individual is approaching a healthcare professional with a respiratory symptom. So how do you assess symptoms? You look for breathlessness, you look for chronic cough. It's important, of course, whenever there's chronic cough, I think India is fully now geared up to think about tuberculosis. We ask for TB testing. We also, if TB is negative, we need to start thinking about COPD. So COPD should be considered any patient with a chronic cough, breathlessness, or sputum production. Let's move this on. Now, how do you diagnose? If you want to treat somebody's diabetes, मुझे लगता है diabetes है, and you started oral hypoglycemic. Does that happen? Oh, I think this individual's got a headache. She or he may have a hypertension. Would you start giving an antihypertensive? But for COPD, yes, मुझे लगता है COPD, दवाई चालू कर दो. That's not the way. We need to do a test. We need to confirm the diagnosis, and that's done very simply using spirometry. I think spirometry over the last couple of decades has really improved. It's gone quite a bit. It's been adopted quite well, and I think we still have miles to go. It's a gold standard for confirming diagnosis. It monitors progression of disease and establishes the severity and the stage of the disease. So I've just got one slide on spirometry, and I think this is the most important slide, which simplifies spirometry. There are 2 or 3 things that you need to see in a spirometry when you want to make a diagnosis of COPD. One is you need to look at the FVC, the forced vital capacity, how much air you can blow out, and that is FVC. Okay, this is FVC here, and the FVC in this particular patient is 5 liters, say. Okay, so 5 liters FVC. Then FEV1 is the amount you can blow out in the first second. Okay, and you make a ratio. If the ratio here is FEV1 by FVC is 0.8, this is normal. Now FEV1 in this case is 1.8, FVC is 3.2. You make the ratio is 0.56. This is obstructive pattern. This is a basic thing which can be used to identify early obstructive airway disease. And now I take the second slide, which is something, again, a simplified approach to diagnosing COPD according to Gold here. So you know you need to make a ratio of FEV1 by FVC, and then you see if it is more than 0.7, it's not an obvious diagnosis of COPD. There may be other features, we'll discuss that, but broadly, no COPD. You look for other stuff. And then if the FEV1 by FVC ratio is less than 0.7, measure post-bronchodilator FEV1 by FVC. If it is less than 0.7, then the COPD is confirmed. So this is the chart to be followed. Now, again, I bring up this slide again just to highlight that, how the colors have changed from 1990 to 2016. And I mean, this is almost 8 years ago, and I'm sure the prevalence must be still higher in a couple of years when we get more data. The problem is big. Air pollution is a big problem. Tobacco smoking contributes only to 20-25%. Air pollution contributes to 50%, of the national COPD burden. And now we come to undiagnosed COPD. So COPD is the 4th leading cause of death worldwide. 70% of the COPD cases are still underdiagnosed, and that's there's an opportunity diagnosed COPD. Patients are not recognized as high risk for future and exacerbations. Pre-diagnosis, patients are treated without a diagnosis, and I think this is not done. We need to treat this with a proper diagnosis. Patients deserve this, and now we know that COPD is has a systemic component. COPD we are talking about in the lung as bronchitis, emphysema, but the inflammation spills over into the lung and is clearly associated with cardiovascular risk. The cardiovascular risk could be in terms of ischemic heart disease, cardiac problems, or stroke. So these are, so whenever a COPD patient is diagnosed, we need to make some risk assessment for a cardiovascular risk and assess from a cardiovascular point of view. So terminology in COPD, you have an early COPD or a mild COPD. Now, early COPD is related to the initial mechanisms that eventually lead to COPD and may really be very difficult to identify in the early stages. But yes, we will discuss this as we go forward. What is mild COPD? A milder form of COPD is measured spirometrically, but it may not feel mild to the patient. Patient may already have a symptoms because by the time you manifest mild COPD, a lot of structural changes have already happened in the lung. And young COPD is in patients aged 20 to 50 years. So that's these are some of the terminology in COPD, early and mild. And now we come to the concept of pre-COPD. That means before the patient has manifested a spirometric COPD, how can we identify pre-COPD? Some individuals can have a structural disease. You do a CT scan, there's emphysema, and they can have a low FEV1. They can have gas trapping. They can have a reduced diffusion capacity. And you will see that their FEV1 by FVC is more than 0.7. On the spirometry doesn't fit into a classical obstructive airway disease, but there were other features which are suggestive of COPD. And I think there's a lot of work in progress, how we can categorize these patients well. At the moment, you can put them into pre-COPD. So pre-COPD is defined as having normal spirometric results, either chronic sputum production, cough, or a MMRC dyspnea scale of more than 2 points at the baseline. So that is pre-COPD. Now we come to a concept of PRISM. Okay, what is PRISM standing for? It is preserved ratio and impaired spirometry. Preserved ratio, that is the FEV1 by FVC is preserved. okay, but the spirometry is impaired. The FEV1 is not normal, okay, and that's what it is. So FEV1 by FVC ratio is more than 0.7. FEV1 is less than 80% predicted, does not meet the criteria of classic obstructive or restrictive lung disease, and then you can think, that whether this individual has PRISM, okay. And if you see, these are the normal FEV1 by FVC ratio. FEV1 more than 80%, obstruction is less than 0.7, restrictive is more than 0.7, and PRISM is more than equal to 0.7, but the FEV1 is less than 80%. Now you pick these patients up and then you start to look them clinically. It's almost like something called as a physician diagnosed COPD or a early COPD. Epidemiological and clinical significance. What is the importance here? The prevalence of PRISM is 7 to 12% of adult population. It's higher in people who are smokers, people who are overweight, who've got obesity, who've got metabolic syndrome, and they may represent. Now, if you have this PRISM, does everybody have COPD? No. It may represent early and mild COPD. It may be obesity related, and it is associated with increased risk of mortality. That is what is evolving, and these people can have a declining lung function and a cardiovascular morbidity. So the prevalence of PRISM in population-based studies, 7.1% to 11%. We discussed that. It's higher in smokers, in current smokers and former smokers, and is also associated with an increased body mass index. So on one hand, we have the pathophysiological hypothesis for PRISM, and on the other hand is the diagnostic workup. What should you do if you have a spirometry result which is suggestive of PRISM? You have smoking-related small airway disease, okay, obesity-related mechanical restriction, subclinical interstitial lung disease can give a PRISM-like a spirometry finding, and in early emphysema also, you can have an FEV1 by FVC ratio which is preserved. So these are all the conditions where which are pathophysiology hypotheses which are associated with PRISM. Now, how do you diagnose? What should you do if you find these patients? How do you diagnose this? You have a detailed pulmonary function test. You look for total lung capacity. You look for diffusion capacity. You assess for emphysema. You assess for interstitial lung disease. And then you also look for symptoms, comorbidities, and lifestyle. You need to put everything together. Okay, there's a new test which is also there, not relatively new, but being adopted in the country, which is our forced oscillometry. I'm not getting into that. We still need to get experience in that. We still need to understand what it represents in our patient population. So PRISM versus COPD and restriction can be evaluated based on this graph. I don't want to get into this, but I've given you an idea of what the PRISM is about and what challenges it gives you. And now let us understand what is the significance of PRISM in our clinical practice. PRISM is not always a stable phenotype and can transition to normal and obstructive spirometry over time. That means an individual who's having PRISM findings on a spirometry after some time can have a normal spirometry, or this individual can evolve into a obstructive airway disease or a COPD. So it has been reported that 20 to 30% of PRISM subjects transition to obstructive spirometry over time. That means you need to have these patients under a close clinical vigilance. We need to tell this problem to the patient, and also to highlight the importance of follow-up. The most important predictors of transition from PRISM to spirometry to COPD are lower baseline FEV1 percentage and FEV1 FVC ratio. That means somebody has a FEV1 FVC ratio of 73% versus somebody having 78% or 80%. So the person who's having an FEV1 by FVC ratio of 72 to 73% is more likely in the clinical scenario to progress to an obstructive pattern compared to somebody who has a higher FEV1 by FVC ratio. Not all individuals with pre-COPD or PRISM will eventually develop a fixed airway obstruction over time and hence COPD, but they should be considered patients because they already suffer from symptoms or have functional and or structural abnormalities, and as such they deserve care and treatment. So these are a very special group of patients who need to be identified and told what their problem is, and I think these are the patients who need a regular follow-up, rather close follow-up and clinical vigilance. So last couple of slides, what are the challenges in the early diagnosis of COPD? 60 to 86% of at-risk individuals do not receive a timely diagnosis, leading to a missed opportunity. A late detection of COPD is related to higher exacerbation rate and increased morbidities. That's a completely different topic about exacerbation prevention, and how exacerbations are linked to increased morbidity and mortality. A general lack of awareness among healthcare providers and patients about early signs and non-smoking related risk factors for COPD. I think awareness needs to be increased on this front. Spirometry is the gold standard for diagnosing COPD, is often underutilized in primary care settings, and I think we need to work in this direction. Maybe there are newer techniques which are evolving, which can help us better. There is something called as FEV1 by FV6, etc. I'm not getting into that. We've really restricted ourselves to an area where we have enough data and where we can focus on the major aspects. So there's a last slide here. What are the major government initiatives that have happened here? Kerala became the first state in India to implement a program at primary care for COPD called the Stepwise Approach to Airway Syndrome Program. National Health Policy 2017 aims to reduce premature deaths from non-communicable diseases, including COPD, by 25% this year. It emphasizes awareness campaigns, tobacco control measures, and improved access to healthcare services for respiratory diseases. And in ICMR, in collaboration with the Ministry of Health and Family Welfare, Government of India has developed standard treatment workflows for managing COPDs, which provides standardized treatment protocols to ensure consistent care across healthcare settings in India. So that's my overview as far as epidemiology of COPD is concerned, with a global perspective, Indian perspective, and the importance of early diagnosis of COPD. Thank you very much. I think now it's next. I think the next topic is will be delivered by Dr. Prahlad Prabhudesai.
Is a pointer, no? Right. Pointer, right?
No, there's a pointer in the slide forward also.
Okay. Thank you. Thank you, Hetero. Thank you for introducing me. And very nice lecture by Prashant. Some points which are there on epidemiology as well as my talk, we will discuss after the lecture. My lecture is predominantly on the translating gold guidelines into the practice of COPD case and discussion. So I may have some questions which I told him to put so that there will be little interaction. So some questions and discussion will probably happen in my talk, and the remaining discussions we'll have together. Okay. So this is a cartoon, okay, in current scenario. You can say that whether it's a politics or whether it's a medicine, anywhere over-aggressiveness causes damage. So you take today's topic is COPD. When you are over-aggressive in treating either with bronchodilators or even with steroids, it's going to harm you. Okay. So wherever it is possible, okay, we should be very, very at the level of where we should interact. So this is what Goal 25 teaches us, as well as managing case. Now this is a case. Ramesh Kulkarni is not my patient, neither my neighbor. Just as a Mr. John, I took Kulkarni as a name. Okay. So he is a 58-year-old male presenting symptoms of preoperative fitness assessment before undergoing elective surgery. He underwent upper abdominal elective surgery. And patient denied any respiratory complaints, no significant symptoms at the time of evaluation. And he has a 10-year-old history of smoking. This is very classical when you treat a patient in the reference is being made in, and we see this patient, we do the lung function. The routine lung functions revealed normal and revealed that there's a moderate obstructive airway disease. But asking questions, no respiratory difficulties reported. Now, the question is, should this patient be treated despite of being asymptomatic? What do you think? I mean, you can answer. There are many respiratory physicians over here. What do you think? Should we treat or not? Yes. Anybody says no? So this is a very common scenario. Whether we should treat this patient. He said, I don't have any complaints. I am smoking, yeah, but I don't have any complaints. You ask the wife says, no, no complaints. He doesn't have anything. So this is a common thing. And the answer is that there are arguments for treatment. There are arguments against treatment. Both is possible. Somebody will say that early intervention could prevent disease progression. It's a very important, valid this thing, but we don't have data on that. Okay. The second is treat symptomatic, frequently exacerbation patient. That's a gold says. Okay. So this is a common problem, and let's see what gold says. That guidelines recommend against routine screening or a pharmacological treatment in asymptomatic individuals without risk factors. So asymptomatic COPD patients should receive non-pharmacological intervention like smoking cessation, vaccination, physical activity if they have anything, exposure and avoidance of and the regular monitoring. So this is a standard approach. So sometimes we treat aggressively, and again, like whatever the cartoon was showed, we may have a problem in the patient. Treatment asymptomatic patient without smoking cessation. Yes, there is a data which shows that asymptomatic or mildly symptomatic COPD patients treated with a 10-week smoking cessation intervention program followed up to around 14 to 15 years, overall mortality rate was reduced in the smoking cessation intervention group versus usual care. So this data is there. So our first approach is always treat the patient which non-pharmacologically is asymptomatic. Okay. So here the patient was not put on pharmacological treatment, and he was just given a fitness for surgery. He was given and surgery was done very successfully. Now, post-operatively, the patient presented with acute cough, breathlessness, treated with antibiotics cough. This may be immediately, or this may not be immediately. This may happen over the period of time. And the repeat spirometry showed decline in lung function. And there is a worsening of obstruction. This scenario is also common. When our patient go home or during the transport from the ICU to the ward or before discharge, they start feeling symptoms. So the question is that should this patient be treated? Answer is yes. What should be the management approach? Gold says that symptomatic patients should be categorized into group. So here there is a guidelines where we should categorize in the group form, and this group is very obvious. You're all aware of all these groups. Okay, ABE. Okay, unchanged. Now it's E group, ABE group. Okay, and we know that how to treat this patient. We do a spirometry for diagnosis, but we use this spirometry only for diagnosis, and we don't use it to follow up. Our follow-up is on symptoms and exacerbation. And this cartoon shows about how it should be. A group, we have got lesser symptoms. B group, more symptoms by CAT score or by MRC classification. And E group has got more than 2 moderate exacerbation or 1 leading exacerbation to hospitalization. So spirometry is confirmed diagnosis, assessment, airflow, assessment of spirometry of assessment is on symptomatic base and exacerbation. This is a guideline. This is how we should treat our Mr. Kulkarni. So now initial pharmacological therapy. Yes, in group A, that is only symptoms. So Mr. Kulkarni has only symptoms. Then you will be a bronchodilators. Group B has more symptoms. He has dual bronchodilator. And if you has exacerbation, obviously it will go into either with the dual bronchodilator, or he may go into triple bronchodilator therapy, triple therapy. So this is how the guideline is there for treating this patient. So group A patient should be offered a bronchodilator treatment based on the effect of breathlessness. Now, how many of you feel that only single bronchodilator is sufficient, or you use routinely dual bronchodilator? This is a common practice question. Okay. You use single. How many use double? to use dual bronchodilator. So what data says, this can be either a short of a long-acting bronchodilator if available, short or a long, and if available and affordable. Okay, and the LABA is preferred choice. This should be continued if benefits document. A patient should be offered a guideline as per the guidelines, self-management of breathlessness and stress, and a given written action plan. We generally do not give a written action plan for the patient, but yes, there is a recommendation that we should guide them regarding the action plan. We should always try to see the comorbidities before we upgrade our treatment. Means what? If a patient is having a single bronchodilator and he will become breathless, before we change, we should always look for a comorbidities. And how the comorbidities are diagnosed? Comorbidities by clinical examination, by further investigation, like Dr. Prashant Chajed said, regarding doing a scan. High resolution CT scan may show comorbidities. Okay, like for example, the patient has got bronchiectasis, okay, or a type of a phenotype, which may be emphysema-like phenotype. This can be obesity. These are all important, simple comorbidities. Okay, deconditioning is another important. He is hardly moving anywhere, and that can also cause more breathlessness on him. So post-operatively, patient has a low symptoms, okay, and he is grouped as a category A and treated with a single bronchodilator. And this is how we treated. The diagnosis of COPD is, again, we discussed, is based on the, Dr. Prashant has already told about all the things, as well as the management is concerned. Here, the initial management is smoking cessation, vaccination, active lifestyle exercise, initial pharmacological therapy, as I discussed, a single or a dual depend upon the response to a bronchodilator therapy, and self-management education, risk factor assessment, inhaler techniques which are to be taught to them, breathlessness management. That is another thing, how we reduce the breathlessness. And that's where the pulmonary rehabilitation plays a great role, where they are told how to reduce your breathlessness despite you are being treated. It is not just exercises, but there are techniques to reduce breathlessness. There are techniques to walk, there are techniques to climb, there are techniques to relax, there are techniques. So all those things are taught over there. And this is something which is very important in management. So you just not only on the stepping up from a dual to a triple, but you have to have the other aspects in managing a patient. Okay. Now, post-op 6 months of bronchodilator monotherapy. Now here there is an increased dyspnea, limiting the physical activity, cough and sputum production is there. There is a drop in the pulmonary function test has happened, and you can say the patient is now categorized to group B. So there is a worsening of the patient. Now, how will you treat this patient? Continue a single bronchodilator, or you start a dual, or there is anything else we can do? Very simple way to go ahead, and practical way. You want to see eosinophil count. Continue the single day. How many of you see yes? Well, so treatment for a guideline says the treatment is should be initiated with LABA plus LAMA combination. If LABA and LAMA is not considered appropriate choice, should depend upon the comorbidity status. So patient's perception of symptom relief is important here, and assessment of, again, comorbidity is very, very important. And then this patient should be investigated further for a comorbidity, where you need an aggressive management, investigation, cardiac comorbidities. It's very important over here. Finding out a pulmonary hypertension in this patient. Too early, but sometimes you have a disproportionate pulmonary hypertension. So this is all which is required. Bronchiectasis, as I discussed. Sleep apnea and other comorbidities which should be never underestimated. So all those things can be considered if LABA and LAMA is not considered appropriate choice by you. So you can still continue that, provided you diagnose comorbidities and treat it. Which agent should be used in these group B patients? LABA, LAMA, LABA, LAMA combination. Now, less effective than LABA plus LAMA combination, LAMA less effective than LABA plus LAMA. So if you are using single, either LABA or LAMA, there is a freedom to use, okay, as per the guidelines. You can have combination. And what is very important, it is shown that the combination is superior than a single. So this is a message. So when you have failure of, if you go step by step approach slowly, then you can understand these combination have a better, and there is sufficient amount of data on that. Sufficient studies are being shown that combination is superior in all aspects: respiratory symptoms, dyspnea index, CAT score, and combination gives significant amount of the combination is your the orange line, remember, okay, than the single. And this is how it shows, okay. So not only in that, even in the improvement of lung function also, the combination has a little better role to play, okay. So now once daily LABA plus LAMA consistently improve the lung function and symptoms in symptomatic, and also reduces the exacerbation of COPD, decrease the short-term COPD worsening, and poses a new safety risk, okay. So that is something which is important to understand. And here in such symptomatically worsening patient, we have a role, dual bronchodilator plays a role. So why this is important? Because we can reduce the cost of the patient. That's very important. And we are also, using the guidelines, so that we get satisfaction, okay. Does explain education is very much required when you are following guidelines. There is no education is required to the patient if you are start putting your medicines under day one of the treatment, okay. Patient will feel benefit, patient will be happy, but you feel that, okay, what I have done, everybody does same thing. I'm a pulmonologist, I should at least change my methodology of practice. So this guidelines teaches us, makes us more happy about managing the patient. There is a lot of scope to discuss with the patient, educate the patient. Can and patient will come back to you if the patient is satisfied. So these are all other things which are there, which are important, and you do practice. I know I don't want to discuss those things. Smoking cessation, how to do it, when to do it, better method to do it. Then rehabilitation, whether it's a permanent rehabilitation or which is a time-based rehabilitation. This is another question which is there. Are ek baar rehab bolega to chalu rakho, or whether we should do rehabilitation for only particular time. That's very important decision you have to make, okay. And vaccination, how will you decide the vaccination? The vaccine, there are government, the gold says lot of vaccines, but gold also has main one important line. What? That vaccination as per your own guidelines of that country. So it's not that every patient should be vaccinated with all the vaccines available. So we have to use our local guidelines, and we can use the vaccination as per the cost. Yes, some expensive vaccines are there, and they are not yet come in our gold guide, our Indian guidelines. So whether to use or not, this is a challenge, and it's your skill also to depend upon how to explain, how to tell them how the vaccination prevents, though they are expensive, how they prevent exacerbation, how they work, how vaccines. Otherwise, patient will claim, I have taken a pneumonia vaccine and still I got a pneumonia. I have taken a flu vaccine and still I got a flu. Okay, these are the common things. So just like the smoking cessation is important, the vaccination also has got a lot of role to play. There are good evidence. I think respiratory syncytial virus is not available yet, RSV, but it has got a evidence A, okay, while rest of the vaccines have evidence B, okay. So if you see the evidence-based point of view, okay, the vaccination has got a fairly good standing. So now Mr. Kulkarni, last 2 years did not report any new exacerbations, was given vaccines, given proper therapy, dual bronchodilator, and he was having rehab program, and he was doing very well for 2 years. And on evaluation, his dyspnea score, CAT score has come down. Okay, his reliever medicine intake also was less. Now, afterwards, as you know, it's a human body, as a machine, he started worsening. So worsening happened on the clinical grounds, increased use of rescue medicine. This is also indicator of worsening, remember, not only symptoms. suboptimal symptoms control across the whole day. So they had a problematic night, day wise okay, but night he had a problems, and reduced lung function. That is also important. So lung functions, follow-up lung function is not required as per the guidelines. But follow-up lung function, whether you stop doing or not in practice, we do, because this is a one way to objectively influence your patient, the preventive measures, that is number one, aggressiveness in your treatment, that can help us to improve his adherence to the therapy, and lot more. So if you show the figures to him, it will help. Okay, whether you are maintained or whether you are gone down, okay, whether you are improved. Does improvement helps? Yes. Suppose there is an overlap of asthma, patient probably may have responded to your therapy to some extent, and the follow-up lung function shows significant improvement. So you may have to change your management. So this is an important way to understand the disease worsening or improvement is happening, and subjective as well as objective measure needs. Now, how will you modify the treatment now? This patient has worsened. Continue with dual therapy, identify his comorbidities, and try to see obesity cannot be tackled in short time. So you have an option there, what to do for obesity, etc., and all that, sleep apnea assessment, etc. Okay, will you add theophylline or not? Correct. So this will all come into your non-pharmacological 100% nutritional. Obesity also needs a nutritional support by reducing his or proper having a nutrition, because this is also a malnutrition. Similarly, underweight patient. Yes, I agree with you. The food is very important. Okay, that will give a lot of strain to the patient. Proteins is important. Catabolic state can be reduced. So add theophylline to the bronchodilator or start a triple therapy. What is your choice? Triple therapy is expensive. How much expensive it is? I think 3 times, right? Huh? Currently, what is the difference, cost difference between the dual therapy and triple therapy? 30% more? No, it's ज़्यादा है. ज़्यादा है.
So dual therapy, single drug is anywhere between 1100 to 1300.
Huh? 900 to?
MIT, then I think it goes to about 900 to 1000. If you take a single drug,
single inhaler therapy, it goes to
1100 to
3000. Yeah. 1300 for generic.
Of course, you go for the patented molecules, it is 3000.
Correct. So much costly when you add other comorbidities like diabetes, lipidemia, etc. So almost huge amount of cost. So the art of medicine is also here to help the patient to reduce the cost. So this is not always just bronchodilator, steroid, triple therapy. So we have a choice, theophylline to be added as a bronchodilator therapy or not. Dual bronchodilator therapy is recommended still, even patient has got worsening, remember. Okay. So here, now recommendation, review symptom, dyspnea and exacerbation risk, history of blood eosinophilia, assess the inhaler technique, adherence, non-pharmacological approach, adjust pharmacological treatment, including the escalation and de-escalation here, consider switching the inhaler devices. Yes, see, so many things we can do to the patient, that whether patient's inhaler techniques are correct or not, device is correct or not, anything like for non-pharmacological approach to be more aggressively treated or not. Assessing can be before we push to triple drug, whether eosinophils are important here or not. And eosinophils, not one. You get back all his previous eosinophils. Nowadays, what I am asking patient to was CBC and IgE levels, you take it separate. And you take a full idea about your trend, which is happening from on the eosinophil count. It works, because one eosinophil count, we generally should not depend, because patient must have received steroids and so many factors are there where eosinophil count get affected. So obviously with this, then we take a call whether it's a dyspnea worsening versus the other things. Okay. So in dyspnea, LABA plus LAMA, and consider the switching the inhaler device, implement a cascade non-pharmacological treatment, consider adding this is a new drug, okay, ensifentrine. How many of you have heard about it? It's still not available, yes, but this probably has got a it's a non-biological medicine, so it will have value. I don't know and it's in inhaled form. Okay, there's a data and good outcome is there. So this is the one drug which we are looking at whether it will come. Second is that in lava lama, again now here eosinophil count which will have a picture to play less than 300, then lava and lama continue, and if there is a less than 100 eosinophil counts, then roflumilast, azithromycin, etc. The drug will come, and roflumilast has been very beautifully given by a gold. Less than 50%, add this azithromycin. I also sometimes, do not really follow this, and after going through a lecture, I realized yes, we should follow. Sometimes we add all, both roflumilast also we add. We want to make the patients very. But again, that cartoon will show us ki, yeah, overuse dependent on the pharmacological therapy may harm our patient more. So aggressiveness we have to little control sometime, and education should be done on patient. So this is what I learned from this today's lecture. Bit little slow and understand it. So this is one thing. And if patient does not respond, then you have eosinophil counts persistently high and is not responding to your triple drug therapy, where they recommend when eosinophil counts is high to add even triple drug therapy. Even they say that even more than 100, if eosinophil counts, you can add if patient does not respond. So there is a scope, even more than 100, more than 300, yes, anyway. But even more than 100, if patient does not respond, you can add that. And if eosinophil count predominant, that dupilumab as a chronic, this is not available still, but who knows, it may come anytime. And this is a one more drug which we have to add in our management of COPD. So this is how a beautiful flow chart is given. So dyspnea management, self-management education, breathlessness management, rehab, exacerbation management, self-management of, again, preventing exacerbation is personalized care. That's very important. So where avoiding aggravating factors is important. So it's not just smoking, remember, it's a non-smoking aspect also should be given importance over here. अरे मैं smoking तो नहीं करता हूँ, so इसका मतलब ऐसा नहीं है कि we will not exposed to environmental triggers, okay, which can aggravate. How to we can say the prevent exacerbation is also important thing, and so many factors are there. Even non-adherent to therapy also leads to exacerbation. That's very important to know. Rehab also improves or decreases regular rehabilitation, decreases exacerbation. So small things, but which can really help us. Okay. So overall, we should have on this is a level of evidence today for rehab. You have a lot of level. There is a level A evidence, okay, for rehab. Education and self-management, there is a evidence B and evidence C, and integrated care have no demonstrable benefit at this time, evidence B, and a strong predictor of mortality. There is an evidence physical activity. What does it mean? So if your patient has to have prolong his life, move the patient. That's very important. If he remains at bedridden, if he remain restricted to the chair, his chances of dying is very high. So that's not important message. Let patient move from his place to other. Let him have his dinner, lunch at the dining table, not on the bed. That's a simple message. Let him go to his toilet, help him to go to his toilet and do his toilet in the toilet room rather than taking a pot. So this is slowly achievable. After putting so many this thing in rehabilitation, I've realized it works. Okay. So we should try to do that. So question is, which mode of delivery you choose here? That's a very practical question. We are India. There are almost more than 35 types of different inhalers are available in COPD. We'll see that. Dry powder inhaler, metered dose inhaler, soft mist inhaler, other device. How many of you want dry powder inhaler to be used? Because dry powder inhalers are in the very, you can say studies are there on COPD in the fixed dose, And combination therapy, they have got in most of the new devices are in dry powder inhaler. So this is something which metered-dose inhaler, we feel that the patient cannot take metered-dose inhaler because they have to use spacer, and many patients are reluctant to use spacer. And even if they want to use a spacer, they have difficulty in pressing the inhaler. Have you noticed that? And obviously taking care of the spacer, handling the spacer. So these are all these things which are important over here. Cleaning the spacer. How many some patients are using spacer for years? So these are all things which are important. So decision is to what is really thing in case any other device which can be useful. Very interesting. The gold decision making, the shared, the gold recommend the shared decision making with the patient is the most appropriate strategy for inhaler device. So partner your patient in the decision making. So any inhaler you use, see the studies when they are conducted, the patients are well known and well versed with that inhaler device. So they are master in using their device. So that study has no value actually speaking in practice. So your patient is not master in that inhaler device. So what it means is that the inhaler device has to be taught to the patient, and patient say bar, see that whether that inhaler device is uses or not correctly. So this is very important. So there are currently at least 33 different inhaler therapies containing different bronchodilator and ICS alone in combination is there. Okay. And at least 22 different inhaler devices are available, including the nebulizers, metered-dose inhaler used without spacer, etc. and all that. So the correct device must be selected. Instruction must be given that inhaler device must be routinely monitor the device, educate on the device, and device must be modified as per the need. So this is what something the message is there. So whatever the inhaler device is there is no need to change the device. That's very important. Whatever device he has, he can use it. Okay. So there is no evidence that nebulized therapy is better than handheld device. This is another message. Okay. So no single device or formulation is found to be superior. This is a gold guideline. Clinical trials may not be representative of standard clinical practice in the real world because the patient involved have mastered the inhaler techniques, received appropriate education, and follow up regarding the use. So this is a actually scenario when the trials are done, and our important thing is that our patients are not mastered anything. Okay. So fixed dose, this is another thing. Fixed dose triple inhaler combination therapy in a single inhaler may help to improve the health status. That is very clear because a single inhaler means he has been trained and that single inhaler only. He doesn't require anything else to know. Okay. Yeah. Otherwise, patient will have everything. Sometimes he takes that. Sometimes he dry powder. Dry powder doesn't work. He uses direct inhaler, and direct inhaler he feels better than spacer. So all these things are there. So Mr. Kulkarni now is managed well for the last 6 years using the bronchodilators and appropriate inhaler. Minimal exacerbation noticed by general practitioner. He stopped taking medicine 3 months ago and resumed smoking. Suffered acute exacerbation leading to ICU care, 4 to 5 days stay, and lung function was assessed later on after discharge. Significant drop in lung function and persistent breathlessness, and patient now progressed to gold group E. Okay, severe exacerbation. So in this scenario, what would be the line of therapy? Put patient on triple drug nebulized therapy, LABA plus ICS, or continue with dual bronchodilator. Triple drug. So yes, Gold recommends triple drug over here. And this is a beautiful presentation of the patient who is already supposed on LABA and ICS for years. What to do? Now my patient is taking salmeterol fluticasone from doctor. I'm ये तो मैं 2 साल से use कर कोई problem नहीं है. So what you are going to do? This is a scenario actually when we see, and these patients are addicted. They feel this is something which they have got it, this inhaler, and this is made a jadoo to them. Okay, so yes, पहला वाला अच्छा था, पहले वाला अच्छा था. This is a human nature. Okay, so what patient is currently on ICS LABA, no current exacerbation, previously positive treatment response, low symptom load, continue the treatment. See, this is the last. If there are low symptom load, don't change. Okay. though we say COPD, and steroid is not the line of therapy. High symptom load, consider the escalating to LABA, LAMA, and ICS. And no relevant exacerbation history. Suppose it comes with the last time we had a discussion, and I said ki continue the inhaler. But the statement they have made is consider changing to LABA, LAMA. So here, when there is no exacerbation and ICS LABA being used by a COPD patient, you can go back to a dual bronchodilator rather than using steroids. So current exacerbation, blood eosinophil count can guide you to LABA, LAMA, or more eosinophil count to escalate to triple therapy. Beautiful flow chart to understand the management. So understanding steroid is very important because I told you that cartoon, you may harm the patient if you use the steroid and by aggressive therapy. So modifies the airway microbiome. So steroid, yes, it modifies the air. Any steroid will apply cause. So we are not aware of that actually, because we think that our study trials doesn't show it. Who knows? This is a drug, so it will definitely modify airway microbiome. Associated with higher prevalence of oral candidiasis that we see. Our gastroenterologists are always telling, esophageal candida ban karo ye, or they will add. So this is also hoarse voice, very common. So not only the singers will be able to tell you immediately that my voice is changed. Okay, skin, and everybody is singing nowadays. All doctors are singing. So so they also say now this affects my voice. The skin bruising, yes, it is seen, especially with salmeterol fluticasone. Blood eosinophil count less than 2 increase the risk of developing pneumonia. There are statements. So associated with increased risk of diabetes, poor control. So all these are known. Okay. And do you think it is there? This is correct or wrong? Bolo na. So we also accept that this is correct. But thing is that we now, for example, pneumonia, where we say, pneumonia आएगा तो हम लोग पहले ही इसको antibiotic दे देते. Where we took X-ray, CT scan of this patient to document pneumonia in patients who are taking inhaled steroid. They come with exacerbation. We never take. We say we just give antibiotic, bronchodilator, corticosteroid. Obviously, it is going to help the patient to come out of that exacerbation. So we never try to document pneumonias. Okay, unless patient pneumonia doesn't mean that he is to be in a hospital. Pneumonia means pulmonary shadows with symptom. Okay, so X-rays, 60% of the lung is covered, 40% is not covered. So we can miss pneumonias. That's why the guidelines are important. We should stick to them. So exacerbation of bronchodilator monotherapy. So role of eosinophil count, as I just discussed. So exacerbation on bronchodilator escalate to LABA, LAMA. Exacerbation of LABA and LAMA escalate to LABA, LAMA, ICS. And if the exacerbation of LABA, LAMA and eosinophil count less than 100, azithromycin and roflumilast. And if exacerbations are there on triple drug therapy, and eosinophil count is less than 100, okay, then we have the other drugs, okay, dupilumab and azithromycin. So these are a beautiful flow chart on the management. These are 3 important trials have really changed the management. So we should know those trials. That name of the trial, impact. I don't want to go into that. Impact, ethos, and tribute studies. Okay, they give us a clear-cut guidelines on the management of triple drug therapy. Okay, and this is something which has changed. Okay, and we should know that, and that's why the goal 25 is changed. Okay, now mode of delivery of the triple drug therapy in this patient: nebulized, DPI, MDI, others. So what it says that, okay, there is a benefit of nebulized therapy in particular group of patients we have to select. Certainly, you will find that metered dose inhaler, though it is equal to nebulized, as Gold has said, but there are gray areas where patient cannot take metered dose inhaler. Patients' partners are not there with them regularly, so that they cannot use the metered dose inhaler through spacer with a mask. That also you can do. And patient cannot press that metered dose inhaler. That's another real fact. Okay, that is pressing a metered dose inhaler is really difficult for our elderly senior citizens. So in this patient who has got cognitive impairment, age comorbidity, reduce the there is a muscular weakness, etc., and all that, unable to handle the inhaler, cannot generate adequate peak flow rate, okay, or adequately controlled by meter dose inhaler or DPI in this patient, where you cannot use both DPI as well as this, okay, we should consider for a nebulized therapy. So he was now discharged with on the regular nebulized therapy, and after 6 months of triple therapy, after that patient was shifted back to triple therapy and no new exacerbation. So now what should be the approach now to this patient? Downgrade or continue or add theophylline as a bronchodilator? Not and Gold doesn't recommend theophylline, but see, these are recommendation. This does not mean that we should not use theophylline. Okay, so you all pulmonologists must be using theophylline, just like I also use. But what is very important in using theophylline is that key dose we have to understand correctly. Okay, definitely intravenous theophylline in exacerbation we don't use, but oral theophylline as a anti-inflammatory or as a dose which we can use, okay, whenever it's required, it has a role to play. But Gold doesn't give that permit. It doesn't mean that it is wrong to use theophylline. I think we had many meetings on theophylline, and we have to have balanced role on theophylline. Understand theophylline pharmacokinetics. That's very important. A cardiac failure patient, cirrhotic patient, patients with other medicines which is taking, okay, theophylline when you are using smokers, okay, maybe patient continues smoking, the dose will be different, okay. So we have to use that. It is very sure that short acting theophylline we don't use. We use a sustained release theophylline, so that prevents the level more than 15. Actually 10 is the level where we get a bronchodilatory effect or even anti-inflammatory effect, even lower dose than that. But more than 15, the side effects start. First side effect is always gastritis. Then next comes the neurological and cardiovascular side effect. Cardiovascular will come first. So if patient has tachyarrhythmias, tachycardias, all underlying comorbidities, we avoid, but otherwise a patient we can still use. Okay. Now, the post hoc analysis of one of the randomized controlled trials that evaluated the effects of LABA-LAMA ICS showed that triple therapy improved clinical outcomes versus dual therapy regardless of smoking status. So that's very important. Okay, so even patient is smoker, triple drug therapy has found to be having effect. The post hoc pooled analysis of 3 triple therapy clinical trials, so in COPD patient with severe airflow obstruction and history of exacerbation, triple therapy improved clinical outcome versus dual therapy regardless of smoking status. A non-significant trend for lower mortality assessed as a safety outcome with the triple inhaler therapy. So this is something which is important to know, that this randomized the post hoc analysis is sometimes very useful to give us a real scenario picture. Very important aspect now. 2 important things which are available to us: oxygen therapy and NIVs. Will you use oxygen therapy in patient? When you will use? So long-term administration of oxygen increase survival in patient with severe chronic resting arterial hypoxemia. So there is a level A evidence. So we should promote oxygen therapy to the patient where it is required. Okay. Of course, this is not patient going to buy unnecessary, but there are a lot of patients who feels that they don't need oxygen. Okay. So these are the patients which we have to tell them regarding importance of oxygen to prime them. Okay. Patient with stable COPD and moderate resting exercise-induced arterial desaturation, prescription of long-term oxygen does not lengthen the time of death or the first hospitalization or provide sustained benefit in health status, lung function, or 6 minutes walk test distance. This is a level A evidence. So we know that resting oxygenation at sea level does not exclude the development of severe hypoxemia when they are traveling by air. See 3 important things where there's an evidence base, and we should try to use this evidence based when we consider for oxygen therapy in the patient of COPD. Similarly, NIV, because constantly now there are 2 things are there in everybody's house. Earlier, Amrutanjan, Vicks, and CPAP. So most of our patients have one CPAP on the desk, like earlier days we used to keep Amrutanjan and Vicks Vaporub, right? So it's like that. So CPAP is very commonly prescribed because of the sleep apnea incidence in India is very high. Okay, we are got craniofacial anomaly and we have structural problems and we have COPD is very incidence is high. We have hypertension, diabetes overlap, so many things in India which is there. Every full, it's a museum of in India. So obviously CPAP is likely to be prescribed, BiPAP is likely to be prescribed. But what about the ventilator support in CPAP? Negative, may improve hospitalization-free survival in selected patient with a recent hospitalization. But NPPP improves the hospital selected patient after recent hospitalization, particularly in those patients pronounced daytime persistent hypercapnia. So this is something which is very important. There is a not very strong evidence, level B evidence in patient with severe chronic hypercapnia and history of hospitalization and acute respiratory failure, long-term non-invasive ventilator may consider. So we use NIV in patients who are frequently getting hospitalized. That is one. Patients has a overlap, of course, of sleep this thing. And third important thing is that it does decreases the overall patient's respiratory fatigue. Okay, so we have a score to, but before asking them to buy the one NIV, we have to categorize our patient and see whether this is going to be useful to the patient or not. So there is a role of that. Now, next important is that surgical role. Mr. Kulkarni is not yet come to this stage. Okay. So now the surgical role is that key symptoms, disorder, and surgical intervention. So symptoms, mucus production, exacerbation, dyspnea, disorder, chronic bronchitis, acute chronic bronchitis, bulla, emphysema. So you have to go with a basically evaluating this phenotype of the patient, what sort of an emphysema it is there. Is a heterogeneous emphysema versus say homogeneous emphysema. Is there any evidence showing the what is his lung function, how bad it is? Okay, how much is the diffusion capacity, what is the FEV1 values, how much is the symptom load? All those things gives us a we have to think what else we can give, okay, to the patient. And then there comes the surgical intervention, and there are a role to play. You know, when to do lung volume reduction surgery, you must have the facilities of the surgeon's availability to operate that lung volume reduction surgery. It has been proven very useful when they operated lung cancer. The patient's FEV1 improved when they did a lobectomy, when the cancer was there in the emphysematous lung. Bulectomies, okay. We had recently a patient with COPD with bilateral multiple bulla with pneumothorax. Very difficult decision, okay, and done very successfully. Our surgeon, no anesthesia fitness was given to, I mean, anesthesists were refused to give anesthesia because bilateral disease, multiple bullae, okay, and one is ruptured. Then patient, how it was operated, we wanted to do bulectomy on one side, where which lung to be selected, how to do, how single lung anesthesia is possible. Patient is retaining carbon dioxide. Okay, so patient was operated by very different anesthesia. We given a low cervical dorsal anesthesia, and patient was operated by that technique. Okay, so without any giving any intubating the patient. So this is how the things are possible. So we should think about surgical intervention whenever it is possible. Any patient going to get benefit of that. Selected patient, of course, transplant is a better option, and bronchoscopic intervention. Prashant will talk about it. We'll ask him question on that. Okay, in this talk only. So there is a rule. There are the evidences. Some level endobronchial valve had level A evidence. Okay, but and lung coils have level B, and vaporization has got evidence B. So there is an evidence. So remember, these are all evidences based because they are very selected patient. Remember, okay, they are not a random patient. So if you have select your patient correctly, there is a scope for this technique. Okay, and there are a lot of other trials are going on newer drugs. So this is about the follow-up of Mr. Kulkarni has been given everything. Okay, and this patient remains complaint-free, and he has stopped smoking. Even 10 years, we can give a good quality life to the patient if we follow this severe COPD patient properly. Okay, so if the patient remains complaints and absence from smoking, even with severe COPD, a stable 10-year outcome, manageable symptoms, and good quality life can be achieved by all these methodologies which Gold says. Okay. So important message is this: ki, early detection, as Dr. Prashant has told us, and there are a lot of questions on that. Okay, will come. Then monitor them and escalate or therapy whenever required. And not only smoking, but non-smoking factors which are also there, which we generally forget. Okay, so those should be also tackled. And post-exacerbations patient, you should give a triple drug therapy in the beginning, nebulized, and later on by inhaler technique. And adherence and the functional stability is very important. And the long-term COPD care must include multidisciplinary approach, not only by just medicines, but so many things: nutritionist, physiotherapist, counselor, all those things, interventional pulmonologist, if the patient is of where he can afford everything, and of course, a surgeon whenever required. So this is a advanced COPD patients have to be taken care. So I think with this, we will end. And this is very important that we should have a discussion on the case as well as the management. I hope that this might have helped you in managing a patient. Prashant, please come.
Had obstructive airway disease. Okay, he was not given any bronchodilator, and post-operative he develops a problem. So what would you have done? If you have somebody in the hospital who's coming for fitness, the PFT is abnormal. Yeah, I think it's very difficult not to treat, because this individual is going to undergo airway manipulation. He's going to undergo maybe an endotracheal intubation. So is it just worthwhile temporarily having peri-operative bronchodilation for this patient?
Yes, I think first most important thing in this patient, besides he should not smoke in the hospital during that time. Number one. Number two is that even in the hospital, we use this patient to tell them about the pre-operative and post-operative physiotherapy to improve the lung exercise, improve the lung volumes. So volume, what we call as a incentive spirometer, which are volume based, where patient improves his respiratory volumes, will prevent the diaphragmatic, post-operatively diaphragmatic related atelectasis, secretions accumulation. So here the physiotherapy will help. I do give a hydrocortisone support to the patient pre-operatively, and may give a bronchodilator for not for the patient's point of view or long-term point of view, but to manage an acute post-operative complication, because all these patients develop post-operative complications where especially this upper abdominal surgery. Below the umbilical surgery, yes, they don't have any problem, but patient with requiring a thoracic or abdominal surgeries, cholecystectomy especially, okay, they will require a pre-operative care, sometime short-term bronchodilator, steroids. The problem is that afterwards, once they have no exacerbation, what they will do, okay? So what do you think? What you will do? Suppose you are treated like you also agree with me, we sometimes give support of bronchodilator, corticosteroids, and physiotherapy at that time. Take over the crisis. Patient is now ready to discharge. Now what you'll do?
So I think what I would do for this particular patient is, I think post-operatively there is a risk that you don't want this patient to have any exacerbation or anything. So maybe for a couple of weeks leave him on that, and then on follow-up you can decide, based on his symptoms, is he having any symptoms or not? And then once he's recovered from his abdomen, there are two options. I think I would talk to the patient. I see the guidelines, but I would talk to the patient. Yes, the spirometry is affected. I think you said there are arguments for, there are arguments against treatment. I probably would err on the side of for, maybe continue to treat him with an option, with properly explained for around 6 to 8 weeks. Once he's recovered from the abdominal surgery, I would repeat the spirometry. If the spirometry shows any change, if there's an improvement, then I think it's worthwhile to have a higher bank balance compared to a lower bank balance.
That is exactly, if you see the symptom-based diagnosis of COPD versus spirometric diagnosis of COPD, that's why spirometry gives a lot of important role to play for diagnosis. Patient underestimate their symptoms. Do you agree?
Yes, I mean, I agree on that. Particularly, when patients say that they are, not having symptoms like Dr. Prabhu Desai said, patient says, I have no problem. The spouse says there is no problem. The question is, how much is the patient exerting? If the patient is just doing a car to carpet to office work, that person may not actually manifest any symptoms. If this patient is going to dance, if he's going to exercise, I think there's a high likelihood that this person will manifest the symptoms.
Absolutely.
Therefore, the spirometry findings and the fact that patient asymptomatic has to be considered in context of the lifestyle of the patient.
Correct. So just like here, there is an COPD being underdiagnosed and he was not treated. Dr. Charger, where the COPD is overdiagnosed? Where are the situation where you find that they are overdiagnosed and we overboard the therapy when patient has actually may not have COPD? Have you seen the scenario sometime like this?
I think over diagnosis I have seen is particularly when the spirometry is not done. Frankly, when it is a physician diagnosed COPD, where patients are just having some cough, which is prolonged cough, patients are giving bronchodilators with the hope that they will respond. I think there is and then the patient says, I had a benefit with the bronchodilator, and the primary doctor might continue the bronchodilators. So seasonal variation may not be. So that may not be COPD. You're talking about seasonal bronchial hyperreactivity. So seasonal bronchial hyperreactivity would be different from a COPD, where you're looking at chronic obstructive pulmonary disease. So I think you're right. We do see seasonal bronchial hyperreactivity. We see geographical bronchial hyperreactivity, where people change geographies and get breathless. I think bronchial hyperreactivity. Prahlad, I think that's one thing. Another one problem I would say is when the spirometry is not performed properly.
Correct.
If the spirometry is not performed properly, then you may overdiagnose the obstructive airway disease.
I think very important to see the graph of a spirometry test. It is not a flow volume curve gives you idea about spirometry. Remember, it's a volume time graph, whether patient has blown to 6 seconds or whether he has blown to 1 second. And this is my observation. Most of the spirometry tests are wrong where they have blown only 1 second. Have you seen that?
Yes, and I think, so that is called as the forced expiratory time. There are certain devices, if you see, which are typically the low-cost devices used by many screening centers. I don't want to name anything. The FET is never more than 2 seconds. So with an FET, not more than 2 seconds. And if you're involving this in your health check programs, there's a very high risk of making an improper diagnosis.
Correct. So flow volume loop here mistakes you that graph is very good. So it means that normal. It's not that. It's a time you should see so that you will not miss. So that is about the any questions from the other team. There are people from Hyderabad and Indore, Kolkata, Bangalore, Pune, Ahmedabad. Please ask questions or please tell your experience also.
Good afternoon, sir.
Yeah.
I'm Dr. Aparna Birajdar from Pune. Sir, I have just few comments if you allow me.
Yes.
So, sir has beautifully given an overview of COPD epidemiology. I would just like to add few points. Like sir had rightly mentioned, only Kerala had a program Shwas. Unfortunately, that was also stalled in 2019. When it comes to epidemiology, like you both have discussed, there is a huge gap of actual diagnosis. And I'm saying this in capacity as a national consultant on a program called Lives. We are having MOU with state government of Maharashtra and Rajasthan. For last 2 years, we have been assisting both these state government for non-communicable disease respiratory part, mostly focusing on COPD asthma. And our centers are Algar district and Alwar, and we are towards expansion. And there are few experiences I would like to share, sir, that one thing, COPD is very underdiagnosed in rural areas, especially working in Palghar district was an eye-opener because of both the factors, especially non-smoking COPD, because biomass fuel exposure in the Adivasi area is also very high. And in addition to that, the chemical industries. Palghar is a hub of all kind of chemical industries, and unfortunately, PHC levels, rather any kind of health arrangements, are very difficult for these districts. Alwar district also again hookah usage very high incidence. So we have been trying to give a full-fledged diagnostic assistance and management assistance with a full-fledged lab with investigations, including spirometry. We have kept EZ1 NDD spirometers. We have kept entire trained staff, including nursing staff and trained technicians and specialist assistants also. And despite that, there are many challenges. I feel these areas are very underdiagnosed. While we are all, most of us are practicing in urban areas, rural COPD burden in India remains very high, and it's not being diagnosed and treated properly. Even during state government training programs, we have realized that after donating spirometers at all PHC levels, also again the same issue of manpower availability, changes in manpower, trained manpower, and availability of drugs. Every training we get that feedback that only darifylline and salbutamol inhalation available. So, like sir said, we need to come up with local guidelines also. Right now, we are working keeping gold guidelines as framework, but we really need to have a national consensus guideline which is updated yearly, just like gold. That is one factor we have observed in the gap assessment studies which we have done at all these centers. And I hope that stalwarts like you both will uh, be on board for contributing more and more towards taking management of COPD in us
Right.
rural areas also to certain.
So yeah, well said. Actually, smoking is the risk factors are also heterogeneous. Government of India has done a lot about smoking cessation. You don't see people smoking nowadays in train, buses, and hotels, etc. But hardly or probably less efforts have been done on the other aspects of non-smoking pollution. So there are so many factors, as I rightly pointed out by you, in the villages, etc. But even in the city, we have a lot of pollution. So Dr. Prashant or anybody would like to comment, what just tell this is it is not that the what governments can do. I'm not saying that the government should do, or but what as a respiratory physician will find the gaps here, that only smoking being tackled care, and where our more than 50% of our COPD is non-smoker, maybe even 80% of COPD may be non-smoker in certain areas, villages.
Hello.
Yeah.
So my question is, hello. Hello.
Yes, please go ahead.
Yeah. So my question is, what are the other causes of non-smoking causes of COPD, except rather than tuberculosis? Please tell your practical experience so that we can avoid.
So
non-smoker
other causes of COPD besides the smoking is pollution at home, pollution in outside the home, pollution in the working place. So pollution. You see outside, you cannot see really. Visibility is very important index which can tell us about the pollution at your place. Okay, so that's very important. So pollution levels are no question, they are high. So we have to do an efforts at all levels. But besides that, one thing is important to know, that low lung volumes which are there in patients or persons, normal people, are going to lead the future to have more burden of COPD. So there are many reasons for have low lung volume. Okay, Prashant, do you think that untreated or poorly treated childhood asthma can lead to COPD?
Absolutely. I think that is one of the etiologies which the Gold has pointed out, that you can have childhood asthma, which is not properly treated, not appropriately treated. And as these progresses, these patients can get into a into a fixed obstruction. So that can be a very important cause of COPD. And also what you mentioned about what we see in our day-to-day life, as far as what is happening in the air we breathe, it's clear. I think the air pollution, the vehicular pollution, the construction related pollution, I think some measures I mean, all of us will have ideas how it can be reduced. But I think one is these gross particle size, which is there. I think the construction sites need to provide a better protection so that the dust doesn't come out onto the streets, etc. Also, the infrastructure work that is happening. I think that I think these are simple steps. When you look at the large volume of investment and expenses that are happening, I think the small measures which can be taken to prevent the spread of the pollutants into the ambient air is a minuscule cost, but will give a large benefits.
And anybody from this gathering have any thought about how to prevent that, or any method, or any idea, or anything, something which can say that this, if you do, you can reduce pollution to great extent?
Anybody from this? Yes.
Yeah, you can.
Yeah, please hand over the mic to him.
You talk about it, whatever you feel.
Pollution. Our national capital, Delhi, is one of the most important polluted city in the world. And what the chief physicians in Delhi are doing, studies come from Kerala, here, Rajasthan, Delhi is the most polluted city. And it is a political question as well as scientific question. It is a political question as well as scientific question. I see young females outside the college, outside offices, teenagers, female smoking. You cannot tell them that please don't smoke. They will straight away tell you, you mind your own business. We know what are the hazards of this. Young females smoking, you feel like telling them that you are inviting trouble for you in the future. As far as prevention is concerned, there are 100 to 200 cars which are coming in Mumbai every day. In Delhi, I don't know how much it must be. So to make them electrical cars instead of petrol cars is a way to
reduce to vehicle-induced pollution.
Yeah, even the buses, they are making electrical.
Yes.
That is also a way to reduce
big roads, traffic jams, all those things, if you can avoid, it is going to have a long-lasting effect on the health of the Indian people. I agree with you. Anybody else?
Sir, I think like NCD, we should also include the COPD in national program according to severity. We have to try for this COPD control program. Either it is polluted, smoking related, or all factor.
Okay.
I add two things, both on air pollution and the current question. NCD has included COPD and asthma national program in 2017. What I was talking about lives in MOU with state governments is under the same thing. Unfortunately, except for Kerala, nobody had started work on that. It is a part of national program. Second thing, what sir was discussing about air pollution mitigation factors, sir, I had been on panel of two discussions. One was with EPIC Chicago, the one with the AQLI index. All of you must have heard the Chicago study. In addition to that, one convention was held by Ernst and Young LLP, where they had suggested creation of low emission zones within the cities, especially pertaining to the high residence areas. Preventing these residence areas from direct exposure to the high vehicular emissions and construction industries, although residential construction will remain in your surroundings. But like sir also rightly pointed out, policy decision makings will make a huge impact, especially with help of the engineering industry, where low emission at source itself is right now our only go-to option because of the high residence density in all the cities like Mumbai and Pune. In addition to that, what sir mentioned about electric vehicles and everything, we had a huge discussion on that. Unfortunately, the pollution generated while creating these electric cars in specific areas is much more than what we see is saved in cities. So like we said, the low emission zones and industrial zones, even including the electric devices or cars creation, the designated area should be separated away from residential areas. That was what the gist was of all these talks.
Madam, can you tell me where you are working and what exactly you are doing, so that you should be our part of our respiratory team wherever we have lectures. And I think Yeah.
I'm Dr. Aparna Birazdar. I'm working as pulmonologist in Pune. So I work in both private sector as well as in part-time capacity under National Urban Health Mission. So I'm
Okay.
associated with both private and public sector.
Okay, thank you very much.
Yes, sir.
So Prahlad, there's one point which Doctor made. So yourself, you mentioned about the seasonal variation. So I think one point I mentioned is bronchial hyperreactivity, but probably there's more depth to what he says, that people who have a grumbling COPD or not symptomatic might start feeling symptoms. You want to expand on that, sir? You mentioned about people come to bronchospasm. Is there any particular season you feel that they are getting more breathlessness, more bronchospasms? Any particular
In a year-
observations?
In a year, just change in the seasons, make them more hypersensitive, and they come with the wheeze. So it is sometimes overdiagnosed by us. It can be a COPD, possibly COPD, before doing PFT and all these things. Our question was going toward that, where we are diagnosing or overdiagnosing the
Right,
COPDs. In such a patient, we always get then confused.
So what would be
Only
interesting
generally
in this patient would be that once you've treated him and once you've got him in a stable state, it's worthwhile to do a PFT, because there are two possibilities here. One is an asthma patient who is getting a flare up, and second, it could be somebody who's got a grumbling COPD is there, like the so-called asymptomatic COPD patient, and the seasonal variation is actually causing a trigger and bringing out the possible COPD. So I think it may not be over a diagnosis. I think you've made a diagnosis of OAD. The only question is you need to move and see whether it's a bronchial hyperreactivity and allergic, or he has an underlying COPD, which is being manifested in an acute setting in a seasonal change. So Prahlad, back to you.
Yeah. So I think we had a good discussion on the epidemiology, diagnosis, prevention, and whatever it is. And Dr. She had also pointed out a lot of things which government should do. Probably she may help. She may be an initial person, doctor, to go into and impact the government or the other public organizations where. Sure. So these are things which can help to sensitize government. That's very important. We have hardly any reach to the government authorities on these grounds. But suppose somebody either a politician or a film industry person develops something, and then the discussion probably
I think
impact.
our Prime Minister has initiated movement 10% cut in oil, 10% cut in ghee, and reduce obesity. So one statement from him, if it comes regarding smoking, pollution, that will also create more generosity in the public.
So now, after going from diagnosis, let's come to a treatment. Okay. Any questions to be points, or anybody wants to add or add to what we discussed, or would like to have comments on what we discussed, or do not agree on what we discussed on treatment point of view?
First of all, I thank both the speakers for their descriptive, illustrative, and very informative talk. What I think is the need of the hour in COPD or as well as in bronchial asthma is to use bronchodilators by inhalation. We see that in practice, many bronchodilators are being given orally, especially in expectorant form. And there is hardly any or less role of drugs like theophylline. So we need a lot of education of doctors as well as creating awareness among patients that inhalation is the best treatment for you, and the device has to be selected discussing with the patients. The other thing I would like to ask is some new drugs are coming in the market or have come in the market, like Ceratodrast or Etrodine. What is the role of these drugs in COPD? I would like to know from you. Thank you.
Well, I think there are new drugs like ensifentrine that is not available, okay, which is inhaled PD3, PD4, dupilumab, which is not really available. Gray market we have prescribed in gray market to some patients, but it's not it's IL-4, IL-13 inhibitor. Then there are tozorakimab. There's something which is drug which is also on pipeline, IL-33. Okay. Then erdostine, which is available to some extent, where Gold recommends it in mucus producing patients, COPD, who has got a predominantly hypersecretions, because hypersecretion leads to mucus impaction, leads to pneumonias, exacerbations, and all those things. So that's why it is one role. N-acetylcysteine was another earlier used for prevention of mucus and also preventing exacerbation, but erdosine has come into the guidelines. Okay, so these are the things. I think then anything else you would like to ask, answer?
No, I think yes, there are new things which are always being discussed. But one thing, the inhalation therapies, they form the primary baseline treatment. All these other things, like mucolytic agents or maybe even the theophylline, etc. These are all supportive therapies, additive therapies based on a particular individual. I
Correct.
think the basis is inhalation therapy. If inhalation therapy given appropriately and if the technique is correct, it does majority of the job.
Sir, one question.
Hello. One
Hello.
question.
We have discussed all smoking related, pollution related COPD. What about sometimes we ask for HRCT chest and it is diagnosed as interstitial lung disease.
Correct.
It's very common. So how does interstitial lung disease predispose to COPD and what is their this thing? I know it is a big subject itself, but interstitial lung disease is commonly diagnosed on HRCT.
Very good. Yeah. So that's why Dr. Prashant has told you beyond spirometry. What is beyond spirometry? Spirometry doesn't include DLCO. Okay. So beyond spirometry means any patient of COPD who is not responding to your line of therapy, and whether after clinical evaluation, auscultating on the patient, if you hear crackles, which is not a characteristic of COPD, it can happen, but Velcro crackles is not a characteristic of COPD. If you get on that, or if patient's breathlessness is disproportionate to the clinical diagnosis of COPD, spirometry being very good, okay, there's a obstructive or may not have obstructive in some patients, but smoker, we always think smoker means COPD, but no, smokers are also exposed to, they are also prone to get a lung disease called respiratory bronchiolitis, ILDs, and all. So this is called phenotyping. When you talk about personalized treatment in COPD, all those things will come. That's why not a routinely, but in an individualized patient, these investigations like doing scan is important, where you can have a combination of emphysema and fibrosis. Does it make a difference to the patient? Yes, because prognosis changes, your approach changes, your hammering the bronchodilator will stop. Okay, once you have a document this thing, you will keep a very limited role of bronchodilator and you may give a lot of other important therapies to treat the underlying interstitial lung disease. Similarly, other is bronchiectasis. Bronchiolitis is another important disease. CTD, collagen vascular disorder, when associated, like a small rheumatoid arthritis patient has. So drugs which are also treated using that. COPD is 70-80% of our patients. You see that incidence, prevalence of COPD is so huge. So there is going to be an overlap of various diseases, including collagen vascular, past history of TB, so many things will come in that. And here
sarcoidosis is very common.
Art of or a knowledge of a chest physician is going to be, and when to use the investigation, aggressive investigation like the HRCT will come. Also, like echocardiography, how to interpret echo in the COPD is another challenge. Okay, when there is a very poor window. So that's another important thing. So I think you are right. So there are so many diseases will come. You want to add something, Prashant?
Hello.
I think.
Can I ask one question?
Yeah.
One more comment. These
This
patients
is-
are prone to a lot of arrhythmias, atrial fibrillation, sinus tachycardia, atrial and ventricular premature beats, pulmonary hypertension. These are the modes by which some of them they die, not because of the lung disease, but because of the cardiac arrhythmias and heart failure.
Yeah, I agree with you.
Hello.
Sir, yeah.
And in real world scenario, we do face COPD patient along with ischemic heart disease. What is your take about beta blocker there?
Well, COPD with ischemic heart disease, this is the most important comorbidities where the prognosis as well as the mortality decides. Mortality comes into picture in management of COPD. And that's why,
Hello.
this phenotype of IHD is important, and we should diagnose them. Or basically, this is an overlap. All, all ischemic heart disease patient requiring coronary evaluation and treatment should be investigated for underlying lung function, about underlying chronic obstructive disease. So they should undergo pulmonary function test, especially spirometry. And all the patient of COPD who are moderately severe, or you can say severe, should undergo coronary evaluation or should undergo the diagnostic evaluation for finding out underlying coronary disease. Okay, that's a probably statement I'm making. I don't know, Prashant, you agree with that or not, or you want to modify it?
No,
or
absolutely. I think what we also discussed is that COPD is just not a respiratory problem. It is an inflammatory state. The inflammatory state goes beyond the lung, and the cardiovascular morbidity is one of the most common. So smoking or the risk factors rather for COPD are the risk factors for for cardiovascular disease. So
correct.
I think evaluation for a cardiac condition, ischemic condition, and also assessing the risk of potential stroke. All these things need to be taken
Cardiovascular,
care.
cerebrovascular,
Hello.
everything.
Cerebrovascular.
Sir,
Yes.
one comment.
My question
Even
is, what about
nowadays
the
they
beta
recommend
blocker?
bisoprolol, cardioselective beta blockers to be given to a hypertensive patient, and they say it does not precipitate spasm. But you cannot be 100% sure. It varies from patient to patient, whatever the pharma companies may say, but any beta blocker can precipitate bronchospasm.
This study was done, I think Hong Kong study, right? Which they have proven now that it's safe to use beta blockers in COPD.
Yeah, it is safe, but you cannot be 100% sure. It may vary from patient to patient,
yes.
And any patient can.
Obviously, I agree with you completely, because there is an asthma overlap sometimes. Asthma, it's beta blockers, especially the older beta blockers are more dangerous.
Even cardioselective
also, yes. I agree with you. I think we have to be careful. Yes, correct.
Hello.
One question.
Ahmedabad. So there is one question from Ahmedabad headquarters. One of our respected doctors from the audience. Just a bit.
Hello, sir. So one of my patients, she's a female, and like she was having ILD, and later she develops all complications of cold pulmonary. Now, sir, I just want to know, like, what is the role of oxygen therapy in such patients? Like now, like when they come, whenever she comes, the oxygen levels almost 80, 85, and always with the history of PND, and then like she's on all medications, like venodilators, we have done diuretics and everything, or cardiac. Other than the cardiac part, like I just wanted the respiratory point of view. So like, what all treatments can help in that, sir?
So I think, what I understand from the question is that, or the point is that there is a patient with interstitial lung disease who has a SpO2 which is ranging from 80 to 85% and is on optimal pharmacological treatment. So whenever we talk about, it may be a COPD, it may be an interstitial disease, lung disease, maybe any chronic underlying lung condition that is causing a compromise in the oxygenation. I think whenever there is an SpO2 which is less than 90% at rest, I think that clearly deserves to be on on long-term oxygen therapy. And I think that is something one should be very generous about using long-term oxygen therapy in these patients.
Yeah. Any question? Otherwise, can I?
Yeah, from Surat, sir.
Yeah.
Yes,
Surat.
from Surat. Yes. So it was very nice talk. Both of you done well, sir. Just want to highlight one thing. Every time when we see the prescriptions in all COPD patients, inhaled corticosteroid is so much of use. But as a respiratory physician, we should always highlight the thing like LABA plus LAMA combination. That's the best way to approach the patient to prevent the complication of inhaled corticosteroids.
Sir, I have one question in continuity
So
with
I think can we respond?
Answer this question.
Can we respond to the earlier comment, please, for Surat? I think, Dr. Prabhu Desai very clearly showed in the COPD guidelines, now the direction is towards you give either a single bronchodilator, a dual bronchodilator, or whenever you talk about triple, you give a ICS. So there is not any place for new patients of COPD to have only an ICS LABA combination. Okay, so please hear that clearly. There's no place for ICS LABA combination in a newly diagnosed patient of COPD. The question will come only if somebody is on existing ICS LABA, and if that patient is stable and has no symptoms, then it may be worthwhile to continue with a, like Dr. Prabhudis I said, with a low symptom load. It may be worthwhile to continue the same because the patient has been stable on that. But I think one has to be very watchful on that and not to deny the patient a potential benefit of a dual bronchodilator. So I think I hope that is very clear.
Yeah, I think after going through the guidelines, gold guidelines, if you go very slowly, a lot of things you learn from them. Okay, it's every sentence is important. So beautifully made. Actually, it's worth discussing again and again. Small things are left actually.
So I think I agree with you. So every time we are doing these sessions, etc., we are reading. I think there are newer things which we are learning and newer things which you are understanding. It's like reading the book 10 times, and the 10th time you read it, you find some new message.
Yes, doctor, you want to ask something?
My question was about the same comment which Chajit sir explained about the low symptom load and no exacerbation patient. So some of the patients are also on the short acting combination of Saba and ICS, and they are also low symptom and low exacerbation. But in that case, even if they're if spirometry is telling you and symptomatically prior history wise also if they're already diagnosed COPD, in those cases, of course, shouldn't we try to bring them to Lama or Lama Laba?
Again, it is a individualized patient. But you are right. If a patient is using 7, 8 times, 10 times, and one inhaler getting over in few days, then of course certainly. But if patient says, I don't require more than an inhaler in next 3 months, 2 months, I think again it can be continued like that. So go a little slow. And as I told you, that the picture of first cartoon is very important. I feel when you are using it, any medications, and that will help us in optimizing a therapy.
I just wanted 2 quick questions. One, sir, combined pulmonary fibrosis and emphysema. How should we prioritize components when treating? Meaning the same way we observe fibrosis for progressive fibrosis in other patients, like PPF guidelines, and simultaneously treat for COPD. I mean, how do you both go about it? And second question is the role of anti-IL-33, because there have been few studies about ipecacutim, if I'm pronouncing it is right, ipecacutimab, anti-IL-33. So any hopes of good results with these biologicals?
Is tozoractamimab is something which is that anti-IL-33.
Anti-IL-33 ipecacutimab, if I can, Sanofi trials have been.
So I don't have any much knowledge on that about that trials, and so I really cannot comment. You want to talk? No. But now, since now we are almost going to end our discussion. But
sir, hello, last from Hyderabad.
No, I'm good. Yeah, okay.
Yeah, from one doctor, sir.
Hello, sir. Good afternoon.
So I think there's a comment on CPFE. I think I think
CPF.
That comment needs to be addressed.
Yes, there are 2 components of one is COPD component or emphysema component, and other is fibrosis component. If you see fibrosis and emphysema, both give disproportionate breathlessness. That's number 1. And their lung functions, if you see graphically spirometry, they are well preserved, but they have got significant diffusion defect. Okay, these people develop pulmonary hypertension also very rapidly. I strongly feel that you have to treat both the component of it. Oxygen therapy probably will help to prevent the breathlessness, and because these are all hypoxic patients and they have disability basically because of cannot catch up because of the low oxygen and fall in the oxygen level. And so, and fibrotic point of view, antifibrotics, as well as currently, at least I can say that and a dual bronchodilator probably will help this patient to manage optimally, and along with oxygen therapy, and of course looking after any other comorbidities which are associated with the disease. That's what I can say. Yeah.
From Hyderabad, sir.
Sir,
we have one question.
Sir, good afternoon, sir.
Yeah.
Hello.
Yeah,
good afternoon, sir.
Yes.
Sir, I am Dr. Srinivas. What is the safe side COPD management and how many days? What is the right treatment?
Sorry, can you just repeat?
So patient having COPD, what is the safe said treatment and how many days?
So I think COPD treatment is typically a long treatment. I think, I think, it's a day, your question can be answered in a day symposium actually. But the point is that once you initiate the treatment for COPD, it is going to be a long-term treatment. What can potentially happen is sometimes you may need to upgrade the treatment.
Long term is how many days or how
Lifelong, so
many
lifelong,
years?
lifelong treatment. sir,
Lifelong.
lifelong,
Thank you. Thank you.
lifelong.
Sir,
So before we end,
one last question. Sir, nutrition is the most important part of COPD patient. They develop muscle wasting, sarcopenia. So what diet or you will prescribe when they are developing muscle wasting or sarcopenia? High
well,
protein
this
diet.
is a talk by itself actually.
No,
but few important things, that smart eating, that's very important because they cannot eat volume. This patient. Second thing, this patient cannot chew also very well because they feel breathless. The chances of aspiration also there. They get bloating. And if the abdomen gets bloated, they will breathless. And then you from dual bronchodilator will go to triple bronchodilator. if the bloating causes breathlessness. So this is, I'm joking, but so many factors are there. Bloating of the abdomen, constipation which they face. Okay, then nutrition also give electrolyte imbalance, sodium, which is their fluid retention. So you can see that how much important is nutrition is there. Okay, from electrolytes to the proteins and even the constipation to prevent, gas to prevent. You cannot eat volume, so obviously they have to always, they may have associated comorbidity. So obviously it's called smart eating. Individualize the patient. Nutritionists are very important over here. They will give you the correct nutrition. But the physicians who are treating also should support the nutrition or probably guide them also, because you can't just leave it to a nutritionist. So I will say that very important component your touch, which we didn't discuss. So before we end, I would like to, from every center, one message if you want to give to other centers or other people, what you will give on COPD overall. One message. Please start from the Hyderabad. One message would like to say, this is most important according to you. Anybody?
So we have one question from Hyderabad. You can take this as the last question. Please kindly answer it.
Sir, one question regarding vaccination, sir. Generally, we will prefer to go for the flu and pneumococcal. Can you give your experience regarding any zoster vaccination? Is it specifically related to any inhalational medication, or is it as a part of routine? Because now guidelines suggesting different types of vaccinations along with the routine flu and pneumococcal. Just need your experience regarding the zoster.
Yes, I think I will ask Prashant. Prashant, the COPD patient comes to you who has got a step B. Okay, you can say that he comes with more symptoms. So you vaccinate where? You vaccinate step 1 or A, B or E or all?
I think I vaccinate all.
Now, can you tell me what your vaccination policy over here?
So the vaccination policy should be towards influenza.
Age less than 50, age more than 50.
So I think the age criteria of less than 50 or more than 50 or less than 60 or more than 60, depending on the country, is for general vaccination. If I find an individual who's diagnosed with a COPD, I think irrespective, that's my take, irrespective of age less than 50, I would vaccinate for both influenza as well as pneumococcal as per the national guidelines.
Will you use 2 pneumococcal vaccine different, 23, or whether you will give only one?
I think I err on the side of giving both the vaccines, yes.
Whether you will use the influenza vaccination, what is the time of your introduction? What type of vaccine you use?
So I think now we have the quadrivalent vaccine, which is there, and typically, yes. So I think that's what I will use. It will be an annual vaccine, and then you have the PCV13, and then you have the 23 vaccine, which typically in a stable patient can be taken at a 1-year gap. If you feel that the patient is high risk, you can take it at a 2-month gap.
Now, as well as the disease, you will force the patient or you will just opt them?
I think we discussed with them. I think, because people have a lot of views and their own views and understandings about the vaccinations, particularly after the COVID. People have a lot of, may have some inhibitions. So typically we introduce it to them. We say, you have a think about it, go on the internet, find about it. But we tell them that, yes, this is something a part of there are national guidelines on this. These have a much better, risk benefit ratio. Yeah, that's
so
what.
Let's complete that. What is your take on shingles vaccination?
I think for shingles vaccination, I think it is ages 50 years or more. That is for the general population. And I think for individuals, who are high risk, we give them a stronger guidance. See, suppose a general population who does not have a comorbidity, it is recommended for 50 years and more. But if somebody's got a underlying comorbidity, has got underlying diabetes, has got an underlying lung disease, has got a cancer therapy, you're going to initiate that individual, you're working up. Say, for example, we had a diagnosis of a chronic condition. We're going to start them on immunosuppressive therapy. I think the first shot, you give the first shot of the vaccine, not only shingles for that matter, but the vaccine should be given much, at the first or second appointment before immunosuppression is initiated.
And have you offered TDAP to them?
No, I think I still have to learn about that.
Okay. So
what is your case on TDAP? What do you do?
I give to some of the patients, yes.
Which of the patients? Which patients you prefer?
Poorly. I mean, I'm talking about COPD.
Yeah.
I'm very bad COPD patients. I give.
Okay, perfect.
TDAP is different from DPT. Remember, that's very important. Okay. So any other? No. We are summarizing. We are ending the talk. No more questions. So I want to have a message from every place. Bangalore has not talked at all. Yeah. So at least you give the message because you are listener.
I think one, 10 seconds. Not you don't have to worry.
Like to give a
Say
message.
something in 10 seconds.
Something. We want to hear from Bangalore.
Yeah. Bangalore is not behind Delhi and Mumbai as far as pollution,
pollution is concerned.
Yes, as pollution is concerned.
I think we wrap up. I think people are tired.
Next.
Yeah. You're saying something? No.
Sir, from Hyderabad.
Yeah.
Sir, it is overall it is a good talk by both the speakers, as well as it is a very lucid and crystal clear about the COPD for public as well as doctors' awareness regarding everything. Thank you.
The message, Bangalore.
Stop the smoking.
Good afternoon, sir. Excuse me.
Sir, a message from
Yes, sir. Sir, we are from Hyderabad. Stop the smoking, everyone.
Sir, one message from Ahmedabad.
Perfect.
Hello.
Got message. Next center.
Ahmedabad, one message from doctor, sir. Just a wait.
Hello, sir. Sir, message is like whenever we are prescribing any inhalations drugs like for to the COPD patients and or any new COPD patients or like the first time, so the giving proper instructions how to take it is very, very important, sir. Like many of the patients I have seen last 10 years.
Proper,
if you don't give them proper instructions,
patient,
they won't be taking properly. So giving instructions how to take it's very important.
Educate on the inhaler devices and inhaler. Very good. Next.
Thank you, sir.
Hello.
I'm speaking from Indore. I must give a vote of thanks to both the speaker for giving a elaborate and useful talk on COPD. Thank you.
I have a doubt, sir. If a pregnant lady with COPD, can we apply same treatment, sir? Is it affects the baby?
Smoking will affect the baby. That much I know. But I don't think about the symptomatic COPD patient, smoker. I will give importance to that symptomatic COPD patient. It will definitely benefit the patient. Patients, if she is hypoxic, oxygenation will improve. That will be more important for the baby. So rather than drugs, which is steroids, that definitely are safe in pregnancy. So inhaled steroid, probably a small dose of bronchodilator. What do you think?
I completely agree. I think the treatment of the underlying condition is important. I think because you really want to prevent a flare-up in this patient. Correct. Because if they get a flare-up with hypoxemia, that affects the patient, the baby in a bad way. Yeah.
Okay. Kolkata message.
Yeah, from Calcutta, I will ask every doctor of my colleagues to get the DFT done properly before starting the therapeutic.
Very good. So we should check our
from
PFT.
Surat, sir. Doctor want to message.
Sir, to spread the awareness, newly detected new diagnosed case of COPD, LAMA combination is the best, not a formoterol budesonide.
Oh, very good. So that you said. Yeah. Anything on from Thane? Thane is also, na? Okay, Thane is good.
Hello.
Yeah.
Sir, both lectures are nice, informative. Thank you for the lecture. But I want to stress that in lecture we have to demonstrate practical aspect, how to use the which specific inhalation therapy like MDI, power dose, that should be included, and a proper method of spirometry which is reliable, that should be stressed in lecture. According to me.
Okay.
To early
Yeah,
diagnosis of COPD and old diagnosis.
So most of the messages are there ki diagnosis of COPD should be done well, and inhaler therapy, whatever you do, should be taught to the patient. And that is what actually the goal also says, that ki inhaler devices education is most important. Whatever inhaler you are using doesn't make much difference to the patient. Okay.
So one
Thank you.
One message from Mumbai.
Mumbai.
Yeah, we should give, like so many states are banning alcohol in their states. Can central government or state government ban smoking in their state?
We'll ask that from Pune. What is her opinion? Madam.
And will people follow it?
Like we said, most of the policy decisions are very difficult to reach upon. There is a huge industry, taxation, income generation. So I don't think ever there will be a blanket ban. But only message from our center would be that along with pharmacological management, preventive measures, including for smoking, non-smoking COPD, and non-pharmacological management should be equally focused upon.
Madam, wherever you do ban more, the alcohol is most sold in Gujarat.
True, sir.
Okay, so obviously there will be more hookah parlors, hookah parties, smoking parties, like that will happen. So no banning actually. Education is most important. Yeah.
PM.
I think thank you both the speakers and all the delegates who are attending other locations. Thank you. I think all the there was a very interactive sessions just now we had. And if you still have any queries, my team will come and take it and we will solve it with our speakers. Thank you. We can end of the program and we'll have the lunch. And thank you all of you to come here. And yes, from Head to Healthcare, this is a continuous process. We will look forward to invite you for my upcoming Palmogad program. My team will come and inform the next program when it is scheduled. Thank you so much, sir.
Very much, sir, for attending this program. And we, as Madam said, we are in continuous process of organizing such programs, sir. Very shortly, again, we will inform you. We have such programs, one Palmogad and the other one is Compass.
Continue treatment, continue program.
Continue program. Exactly. So let us join us for lunch, sir, in the restaurant. In the restaurant.
Sir, actually, we have a Hindu hospital with also. Therefore, we have the 300 meeting hall. Just to someone in the meeting, we can offer entire day.
Yes.
We can serve all. Every meeting we conduct this.
Yeah, it is a class apart kind of hospital, sir.
Or we can take care.
We have an auditorium also there, where it's one of the class apart kind of auditorium. In case if doctors wanted to have any kind of such sessions, scientific sessions, we can provide in that hospital.
So it is a good program. We help to get the doctors and family. No matter your plan, okay, help to profit about doctors. Neutral chair, interest right. The nutritionist and the general motivation. So what we invite just now 15 members all reasons next reasons. Also we should be because nice small message.
Yeah, there's a lot of stress is there on the doctor. So how to overcome this stress?
Good idea. Compared to normal people, 6 to 8 years, munde problems vasthayi konni.
check.
कोलकाता में हो गया उसने लिखा है check. Hello.
Yeah. So, good afternoon. This is Dr. Bhaumik Kandar here from Malad, Mumbai. Yeah. Yeah. Okay. Yeah. So, good afternoon. This was Dr. Bhaumik Kamdar here from Malad, Mumbai. So it was very nice attending the program. All the recent updates regarding COPD Goal 2025, it gives us a new perspective in practice as well as how do we go about for a busy clinician per se, what new can be done for our patients, and also helps us connect with other our colleagues. And overall, I would say it was a good experience learning about it. I would like to thank Hetero Healthcare for such educative programs. Thank you very much.